Welcome. Today we're diving deep into a fascinating yet often overlooked kidney disorder, Gitelman syndrome. It's a rare genetic condition that affects how your kidneys handle electrolytes, the tiny charged particles essential for everything from nerve function to muscle contractions. Get ready to unravel the complexities of Gitelman syndrome, from its origins to its management. So, what causes Gitelman syndrome? It's all about genetics. Gitelman syndrome is inherited in an autosomal recessive manner. This means that an individual must inherit 2 copies of the mutated gene, one from each parent, to develop the condition. The culprit gene is primarily SLC2LA3, which provides instructions for creating a protein called the thiazide-sensitive sodium chloride cotransporter, or NCCT, located in the distal convoluted tubule of the kidney. Mutations in this gene lead to a non-functional or poorly functioning transporter. Now let's talk pathophysiology. The NCCT transporter, when functioning properly, reabsorbs sodium and chloride from the urine back into the bloodstream in the distal convoluted tubule of the kidney. In Gitelman syndrome, because of the faulty NCCT transporter, this reabsorption process is impaired. This leads to a chronic loss of sodium and chloride in the urine. This loss triggers a cascade of imbalances. Your body tries to compensate by increasing potassium excretion, leading to hypokalemia, low potassium levels. It also stimulates the reabsorption of calcium in the kidney, resulting in hypocalciuria, low calcium in the urine. Furthermore, the body can become alkalotic, meaning the blood pH is elevated due to electrolyte shifts. Finally, magnesium wasting can occur, leading to hypomagnesemia, low magnesium levels. Gitelman syndrome is considered a rare disease. Its exact prevalence is difficult to determine, but estimates suggest it affects approximately 1 in 40,000 individuals. It's found across different ethnicities and geographic locations, although some populations may have a slightly higher prevalence due to founder effects, where a particular mutation is more common within a specific group. The signs and symptoms of Gitelman syndrome can vary widely. Some individuals may be completely asymptomatic, only discovering the condition through routine blood work. However, others experience a range of symptoms, which may include muscle weakness, muscle cramps, fatigue, salt craving, dizziness, thirst, and nocturia, which is excessive urination at night. In some cases, individuals may also experience tetany, which is involuntary muscle spasms, or chondrocalcinosis, calcium deposits in cartilage, particularly in the joints. It's important to remember that the severity of symptoms doesn't always correlate with the degree of electrolyte imbalance. Diagnosing Gitelman syndrome typically involves a combination of clinical evaluation and laboratory testing. Blood tests often reveal hypokalemia, hypomagnesemia, and metabolic alkalosis. Urine tests usually show low calcium excretion, confirming hypocalciuria, and elevated chloride excretion. Genetic testing can confirm the diagnosis by identifying mutations in the SLC2LA3 gene. Additionally, a thiazide diuretic test can be performed. In healthy individuals, thiazide diuretics inhibit the NCCT transporter, mimicking the effect of Gitelman syndrome. In patients with Gitelman syndrome, administering a thiazide diuretic typically does not significantly worsen their electrolyte abnormalities, because the transporter is already functionally impaired. Gitelman syndrome does not have distinct classifications or types. It's primarily caused by mutations in the SLC2LA3 gene, leading to a similar pathophysiological process in most affected individuals. However, there can be some variability in the severity of symptoms and the degree of electrolyte imbalances, which can be attributed to other genetic factors, environmental influences, or individual differences in response to electrolyte disturbances. The treatment of Gitelman syndrome focuses on managing the electrolyte imbalances and alleviating symptoms. There's no cure for Gitelman syndrome. Potassium supplements are often prescribed to correct hypokalemia. Magnesium supplements are used to address hypomagnesemia. In some cases, potassium-sparing diuretics like spironolactone or miloride may be used to help reduce potassium excretion. A high-salt diet can help compensate for sodium loss. Regular monitoring of electrolyte levels is crucial to ensure appropriate adjustments to treatment. Nonsteroidal anti-inflammatory drugs and NSAIDs can exacerbate salt wasting and should be avoided. Unfortunately, there's no way to prevent Gitelman syndrome since it's a genetic condition. However, genetic counseling is essential for individuals with a family history of the disorder who are considering having children. Genetic testing can determine if individuals are carriers of the mutated gene. If both parents are carriers, there's a 20% chance that their child will inherit Gitelman syndrome. The prognosis for individuals with Gitelman syndrome is generally good. While it's a chronic condition that requires ongoing management, it usually doesn't significantly impact life expectancy. However, the electrolyte imbalances can lead to complications such as cardiac arrhythmias, muscle weakness, and growth retardation in children if left untreated. Recent research is focusing on identifying potential therapeutic targets to improve electrolyte balance and reduce the need for lifelong supplementation. Further understanding of the genetic factors that influence the severity of Gitelman syndrome is also being explored to personalize treatment strategies. Thank you for joining us on this exploration of Gitelman syndrome. We hope this information was helpful and informative.